With its curved shaft design, the NANOS short stem is very suitable for the anterior as well as anterolateral, lateral and posterior approach. For the anterolateral approach, it's recommended to position the patient on an operating table that allows hyperextension of both legs. For minimally invasive approach, the patient is placed in supine position at the edge of the operating table, and the leg to be operated on is disinfected and draped in the usual manner. If the contralateral side already has an implant, it may be advantageous to wash both sides. We mark the incision line longitudinally and laterally over the greater trochanter, using the anterior superior iliac spine as a landmark. Undisturbed anesthesia is necessary for the operation. Muscle relaxation can be achieved by general anesthesia or spinal anesthesia, which should reach the thoracic level 7 or 8 to produce a sufficient relaxation of the hip muscles. Later on, the lateral skin incision is not directly visible for the patient when viewed in a mirror. An anterolateral approach is used within the soft tissues. The straight skin incision is usually 6 to 8 centimeters long. The fatty layer is sharply incised, and in vivo, careful hemostasis is particularly recommended for obese patients. Additionally, expose the fascia lata for 2 centimeters towards cranial and caudal. This allows subsequent controlled reclosure. The tensor fasciae latae muscle shines through 2 centimeters above or anterior to the fascial dissection. Sever the fascia with an arching incision, known as a smiling incision. This incision shape prevents the fascia from tearing in caudal direction. Also, sharply incise the trochanteric bursa. If there are clinical symptoms or an abnormal aspect, it should be resected. The surgeon now runs his index finger along the femur towards caudal over the vastus lateralis muscle. With a rotating movement of the finger over the anterior femur towards the femoral neck, the surgeon carefully searches for the muscle gap behind the insertion of the gluteus medius muscle. When this gap has been definitely located, a narrow Hohmann retractor is introduced into the piriform fossa. This can be used to stretch lateral fibers of the gluteus medius towards cranial. A broad Hohmann retractor supported by the finger is then placed over the ventral edge of the acetabulum. The position of the narrow Hohmann retractor can be optimized if necessary. Insert a blunt Hohmann retractor towards caudal over the longitudinal capsule of the hip. The hip joint capsule is now visible. Clean up the pubofemoral ligament. A small arched incision extending to the labrum is helpful to now carefully introduce the broad Hohmann retractor horizontally. This should rest directly on the edge of the acetabulum, while towards ventral it protects the femoral nerve and the vessels. Now open the hip joint capsule with a double wing door-like incision towards cranial and caudal. Make a central incision on the femoral neck, followed first by lateral, then by medial capsule incisions. Thickened fibrotic capsule material should be resected, since it could later cause soft tissue impingement. Caudal capsule preparation should be performed under visual control, with a scalpel blade facing towards the femoral neck. This technique can prevent injuries to the nearby branches of the deep femoral artery. For minimally invasive treatment of femoroacetabular impingement, the capsule can also be opened with a Z-shaped incision to ensure that the medial femoral circumflex artery remains intact. Now introduce the blunt Hohmann retractors under the capsule and abutting on the femoral neck. Now identify the head-neck transition to determine the resection plane. Depending on the patient's height and the preoperative planning, perform the osteotomy 5 mm to 1 cm below the head-neck transition. At this stage, it's also possible to assess the femoral head torsion and acetabular roofing. This enables the surgeon to visualize the later position of the implant. Under the protection of the Hohmann retractor, cut through the femoral neck first at mediocaudal and then at laterocranial. This ensures that the prosthesis will rest straight on the Adam's arch. The leg can be externally rotated slightly, but the saw should not be tilted towards the greater trochanter to avoid unnecessary bone or soft tissue lesions. A broad osteotome protects the femoral neck while the corkscrew is screwed in completely. The femoral neck can be further protected by using a broad bone skid to assist the femoral head removal. With one hand, grip the corkscrew close to the femoral head. With the other, grip the corkscrew handle and push downwards. This allows the femoral head to be gently levered out. Inspect the femoral head. In this case, you can see that the resection plane is too close to the head. Under the protection of 2 Hohmann retractors, resect a bone slice of the required thickness. At this stage, it's also important to protect the gluteal tendon and to ensure smooth resection to avoid fracture sites. Some surgeons prefer to perform the femoral head dislocation before the osteotomy. Also, when using this technique, the osteotomy height should be determined according to the anatomical conditions and the preoperative planning. It's also advantageous to place compresses or abdominal drapes around the Hohmann retractors through their holes. By this means, the surgeon's view is not obscured by the assistant's hands, and the assistant's hands are protected from the instruments. Leave the broad Hohmann retractor in place over the anterior acetabular edge. Then introduce a double prong retractor under the dorsal acetabulum. It may be helpful for an assistant to extend the patient's leg for this purpose. In operations with only a single assistant, this retractor can be stabilized with a suspended weight. Place another Hohmann retractor, pointed, narrow, or blunt, above the acetabular notch at about 2 o'clock. Now we can see the entire aspect of the acetabulum with the labrum and acetabular fossa. Remove the labrum around the entire circumference and free the acetabular fossa from soft tissue. Perform careful hemostasis with an electrocautery device. Free the acetabular circumference from exophytes. On introducing the first reamer, a ventral and lateral exophyte can be carefully removed. Anterolateral, minimally invasive acetabular preparation can be done using a bayonet type or a straight reamer. For the R3 acetabular shell, stepwise reaming is performed by the usual technique. The sclerosis should be penetrated, petechial bleeding should be visible, and the bone of the acetabular margin should be exposed. Adjust the closely fitting reamer to orthogradely, usually with an antiversion of 15 to 20 degrees and inclination of 45 degrees. For dysplastic hips, it's recommended first to prepare the shaft and assess the hip in the reduced state with the trial impactor with the trial head fitted. If the antitorsion is increased, the acetabular shell can be positioned more openly, whereas with lacking antitorsion, it is hammered in roofing position. The correct introduction of the cup in this manner also avoids prosthesis impingement when anomalies are present. Now check the fit and stability using the trial cup. In the present case, it's advisable to repeat the reaming operation. The cup is lowered further and the marginal sclerosa is broken open. Before implanting the cup, remove the reaming debris and rinse the cup. If required, perform spongioplasty before cup implementation by introducing the reaming debris of the head spongiosa as filler material into the acetabular notch. Assemble the R3 acetabular cup with the impacting instrument and introduce it into the site. The surgeon should ensure that the skin is disinfected and that the cup does not come into contact with the skin. Introduce the cup into the planned position and turn it such that screws can be anchored firmly in the pelvic bone if necessary. Adjust the impacting instrument to ensure that the skin is not compressed during impaction. Drive in the cup with the hammer. Here we can see that the cup is firmly anchored on rotation, levering, and tensile loading. Release the connection to the impactor, remove the impacting instrument, and check the position of the cup. Remove any bony residues and smooth the outer edges, then clean and dry the cup. To obtain a good range of motion and prevent dislocations, the largest possible head-liner combination should be chosen. Various sliding implant combinations are available for this purpose. First, a trial insert can be used and then exchanged for the original liner after checking the mobility of the extremity. The original liner should also be placed in the cup without skin contact. The plastic impactor can be used for this purpose. A step-free transition to the edge of the acetabular cup shows that the liner is correctly positioned. When changing the liner, the recess at the edge of the R3 cup makes liner removal easier for the surgeon. The patient's position is unchanged at the edge of the operating table. Usually the legs are lowered by 30 to 40 degrees on the table, and the leg to be operated on is placed in the figure 4 position. In this case, lowering of the legs on the table is not possible. Placing the operated leg below the other leg with adduction in 90 degrees external rotation greatly facilitates the femoral preparation. Insert a narrow, in this case double-prong Hohmann retractor between the greater trochanter and gluteus medius tendon. The more retrogradely curved this retractor, the easier the preparation. A second Hohmann retractor protects the soft tissue towards medial. The surgeon now takes up his position in axial direction in front of the femoral bone. The femoral head torsion and femoral axis are taken into account when using a broach to open the medullary space. The broach is turned outwards and introduced in axial direction centrally into the spongiosa of the femoral neck. The tip is directed towards the knee. In soft spongiosa, the medullary space is easy to locate. In the firm spongiosa of active patients, the canal should be approached very cautiously with light rasping movements. The axial direction should be repeatedly visualized to ensure that this broach is introduced correctly without rasping into the soft tissue. The last 2 to 3 centimeters can then be rasped with the broach in neutral position. This procedure is complete when the cutting teeth of the broach have disappeared completely into the medullary space and the broach tip has rasped the lateral spongiosa flat in the region where the tip of the implant will later be located. Applying small blows, carefully impact the first and only femoral broach into the medullary space, where it follows the anatomical anti- or retrotorsion of the femoral neck. When introduced in an arching manner, the broach slides along the lateral cortical bone into the medullary space. This can be made easier by using double offset instruments. The broach should be introduced axially to protect the soft tissue. The gluteus tendon is protected under the retractor. Aim the first impactor in the same direction as the broach. Sometimes the impactor should be pressed more in the direction of the patient's body to increase the opening of the dorsal femoral neck. Since the impactors are wedge-shaped, a large number of small strikes help in compressing the spongiosa. Listen to the sound of the instruments during this process. The impact should be applied with the same force, carefully opening the canal by hammering in and out multiple times. The anti-torsion should also be remembered when using the next impactors, and the femoral neck should be opened as centrally as possible. The lateral ring of the femoral neck should occasionally be widened with the broach to prevent it splitting open. If the sound changes while driving in the impactor and it becomes firmly lodged, fit the trial head and perform an inspection under fluoroscopic control with the hip reduced after removing the leg hyperextension and in 10 degrees rotation. This can be facilitated by tying the feet together with an abdominal drape. After dislocation and resuming the figure 4 position of the leg, remove the impactor. If the osteotomy surface and the end of the impactor is perfectly aligned, a larger size can then be used, especially with small sizes, if appropriate again using a broach and with careful compression of the spongiosa. If the impactor is tightly anchored, as it is here in this cadaver site, after the surgeon has performed a check, it can be removed and the original prosthesis can be introduced without skin contact. Hammer in the prosthesis with blows of equal force using a punch-like impactor until it becomes tightly lodged and the sound changes. It may be advantageous to redetermine the neck length of the prosthesis head as S, M, or L. Then impact the head onto the cleaned and dried 12-14 cone. Repeat the stability and impingement tests in the reduced state. The stability tests correspond to the usual procedure. No impingement should occur on extension in external rotation or on flexion and internal rotation. With age-associated coxa vara, reconstruction of the normal CCD angle would be indicated. This results in slight lengthening of the operated side until the contralateral side is also operated. After implantation of the original prosthesis, we first test the maximal external rotation, which in the present case is about 70 degrees without impingement. Then we restore the normal position and perform telescope testing without impingement in hyperextension. Here the flexion test shows over 120 degrees with stability of internal rotation flexion. The leg length should be equal. Inspection of the access site reveals an undamaged tensor fasciae latae muscle and the tractus incision. The gluteus medius muscle and tendon are also seen to be intact and can be palpated with the finger. Abundant tissue irrigation prevents ossification, although this is very rare when using this approach. Nevertheless, we recommend a prophylaxis with an anti-inflammatory drug, careful monitoring of bleeding, and if necessary, drainage. If individual ventral fibers of the gluteus are lacerated, refixation with Vicryl is possible. Usually, however, only stable fascia readaptation is necessary. In this case, 4 finger breadths represent a tension-free 8 cm access. For demonstration, the leg is again placed in the femoral preparation position to remove the prosthesis. The removal instrument is screwed like a clamp over the femoral neck. This can also be done in a minimally invasive manner. The screw is tightened and the extraction can now be performed in axial direction using the impaction instruments. The 3 following images answer the question whether modularity is necessary for offset reconstruction. In the image on the left, the NANOS shaft steeply follows the coxa valga. In the middle image, it is harmoniously centered in coxa normala. In coxa vara, it follows the anatomy, It is introduced with a flatter profile, and the prosthesis tip is touching the lateral cortical bone of the femoral diaphysis. Mobilization with full loading would be possible. We recommend partial loading with 20 kilograms for 4 weeks and walking crutches for 6 weeks to gently promote soft tissue regeneration and muscle formation. The bonite coating makes for more rapid bony integration of the prosthesis compared to conventional coatings, corresponding to the usual bone healing time in the femur, depending on age, blood circulation, and nutritive supply, among other factors.